We're so glad to have you here to learn everything we can about improving our revenue cycle. And while we get started, I'm just going to launch a poll just to get some information before we go. Here we go. So a few housekeeping items, just a heads up that the webinar is recorded and everyone who's registered for the webinar, regardless of whether you could make it today, will receive a recording and a copy of the slide deck. So please feel free to use the Q&A or the chat function. If you have questions for us, you can also use the raise your hand function, and we'll do everything we can to get to your questions. If we're not able to get to your questions during the session, we can keep track of them and get back to you individually the best that we can. And we really appreciate you being here with us today. So I'd like to go ahead and introduce you to my colleague, Amy Graham. Amy's going to start us off today and lead our session. Amy leads Stroudwater's revenue cycle practice. She's a principal here with us and has over 20 years of experience in the revenue cycle space, working with all kinds of different organizations, rural, non-rural, big and small. And we're so glad to have her here at the firm with us and to work with you today. So,
thanks, Hillary.
Amy?
Oh, yeah, thanks, Hillary. Hey, y'all, thanks for joining us on our revenue cycle boot camp. Really excited to talk about all things revenue cycle. The thing Hillary didn't say, but if you've talked to me before, you know that I really have a passion for talking about it, and my family has a passion for having you talk to me about it, so they don't have to hear it as well. So thanks for joining us. A little bit about Stroudwater. We're not just revenue cycle. We've been in the business for 39 years working in that rural healthcare market. And so we really just have a passion about that with different opportunities. But today, when we talk about, we are specifically focusing on revenue cycle. And we talk about this. This is what I mean when I say revenue cycle. I talk about things that happen pre-claim activities before you even think about the first patient coming in the door, contract negotiations with your payers, payer and provider credentialing, EDI, ERA enrollment, banking setup, CDM creation, price transparency. Some of my colleagues, I look at them and I'm like, well, that's great. You want to do this and everything, but how are you going to get paid? And so that's really where it starts. And then it's bookended by the back end side with analytics, where you're looking at cleaning meaningful data. What does that look like? If you're going to manage it, you need to be, or if you're going to measure it, you need to be able to manage it, or manage it, measure it, back and forth. And then when you talk about, out there as the claim life cycle itself, front end activities, those patients who come in with their pre-visit scheduling, registration, insurance verification, prior authorization, appointment reminders, then the patient, we've done all of these things and then the patient shows up. You have visit activities of patient check-in, copays and deductibles, collecting those, patient payment arrangements, coding and charge captures, and counter documentation. And we've done all of this stuff. And then all of a sudden we have claim submission. What does that look like? So we think about things in claim submission, charge entry, claim scrubbing. Do your claims go out the door? Pre-adjudication. What happens when it hits that clearinghouse? What gets sent back? EDI management. How are you managing that information going back and forth? You also have inbound transactions that come through. Mail processing. Do you still get mail? Where does it go within your facility? What does that look like? Bank deposits, ERA, EFT processing, those files coming back and forth, payment posting, revenue allocation. And then finally, all of us who are in revenue cycle, it's like, people are either going to think about billing or collections. That's usually what they refer to us as. You have those activities in that accounts receivable management where you're working on claim status, denial management, appeals and resolutions, patient statements, patient notifications, patient refunds, small balance write-offs, collection process. Does it make you just want to like exhale and be like, no wonder I'm tired? And then all of these things that take place as part of revenue cycle management. You've got month-end closing, cost reporting, compliance, performance management, IT quality. All of the activities that we do in revenue cycle management really support these things. So, Hillary, I believe we've got a poll out there. You want to kick off our first poll for everyone to complete as part of this?
Sure, Amy. So we've got I'm going to end the pre-survey,
Okay.
and here we go.
All right. So the next question, I'll go ahead and launch it. I've got it here.
Okay,
All right. So
there we
when
go.
you think of revenue cycle management, all of these things that I just talked about, where do you see the biggest challenges out there? Yeah, I see a lot of answers coming back. Okay, it looks like it slowed down a little bit. I'm going to go ahead and, well, they're still coming through. We'll give you about 10 more seconds. All righty. All right, I'm getting ready to end it in 5, 4, 3, 2, 1. All right, ending the poll. Let me share the results. These results are really fascinating. When you think about you're talking in the rural community and everybody's like, my challenges are in staffing, my challenges are in staffing. But that's actually like the smallest area that we have as challenges out there. Where right now it looks like 41% of you have challenges in denials management and claims processing. 33% have challenges out there. Your biggest challenge in revenue cycle is in that patient registration front end. And then, 14% and 12% coming in with that revenue cycle assessment and optimization. And it's like these are challenges that we face every single day as part of just our day to day activities. And with revenue cycle, I always say it's like we're the tick on the tail end of the dog. It's like we're not just the end of the process, we're the end of the process. So, with that, I'm going to actually introduce, we're going to turn this over and start having a panel discussion. We're going to talk first about revenue cycle optimization and just thinking about that, an assessment that was done at Mahaska Health. And JD, I know you're out there. He's a principal and one of our board members. He is not in revenue cycle, so it's going to be fun to listen to him ask these questions, mainly just to facilitate the discussion, but then have that outsider's perspective on it as well. So welcome JD to the panel, and let's go.
Sure. Thanks so much, Amy. It's a pleasure to be here listening to words that I don't understand. As Amy mentioned, I am not part of the revenue cycle team at Stroudwater. I've been here for 15 years, though, and what I've realized is that I think revenue cycle people speak faster than anyone else. That's out there. Prior to Amy, our revenue cycle folks were really fast speaking. And as someone that used to be the fastest speaking person in the firm, it is good not to be that person any longer. Amy certainly has that. But it's not just Amy. Ryan Brenneman, Dr. Ryan Brenneman, also is part of our revenue cycle team, and he's been with the firm for several years now, but he comes to us as one of you. He was once on your side of the table from a revenue cycle perspective, and then just decided, hey, now I want to be able to share that gift with rural hospitals around the country. So thanks for jumping in, Ryan.
Absolutely. Thanks, JD. Happy to be here. And like you mentioned, I have been on that side of the wall for a long part of my career. I have been in revenue cycle for about 25 years, VP of large revenue cycle organizations, smaller billing, quote unquote, billing shops as well. But yeah, happy to kind of be a part of that and move over to that Stroudwater side as a consultant and kind of provide that knowledge base as well. Along with that, and kind of like Amy mentioned, part of this first piece of this boot camp is we are going to kind of discuss what we have done with some things with Mahaska. And I will introduce Kendall Donnelly and let her kind of provide some of the background of her background and kind of tell us about herself and kind of where she comes into this picture before we join into this, I guess, roundtable discussion.
Excellent. Thanks, Ryan. So I'm Kendall Donnelly, Executive Director of the Revenue Cycle here at Mahaska Health. We are the second largest critical access hospital in the state of Iowa. We are in southeastern part of the state. I've been with Mahaska about 7 years now. Came from a very large professional organization for providers up in West Des Moines. So this was definitely a culture shock for me. But honestly, Stroudwater became a part of my life pretty quickly in 2019 when I first met with them. So this is exciting to be here. And I'm excited for the questions.
So I do have it. I'm going to interrupt already, JD, but I do have a question for you, Kendall. You're at a critical access hospital. That means your hospital is 25 beds, right? And you've got some rural health clinics out there and other clinics.
We are, yep, we're 25 beds, so we are the maximum capacity for a critical access hospital. You can't have one more than 25, or else you go into a PPS facility. That's correct. We do have a couple of smaller clinics. We do not have rural health. We don't have rural health or federal or FQHCs, but we have a little clinic up in a town just north of us, about 15 miles, and then we have a university here in town that we have a clinic at. And we are looking at a couple of other little towns around us to maybe just put a little clinic in. But saying that and saying we're critical access does not mean we're small. Like I said, we're the second largest in the state. So we have a lot of specialties here at Mahaska Health, along with our 25-bed inpatient, which seem to be full most of the time lately.
Mm-hmm.
So Kendall, what's been going on in terms of your revenue cycle management team at Mahaska? Have you had changes from, I mean, we talked earlier, everyone thought it was staffing was the big issue. It turns out, at least in the poll, that wasn't the big issue. But tell us where you're at out there as a larger critical access hospital.
Yeah, no, that poll was spot on. I could not agree more with the way that poll ended. Denials management, honestly, huge, huge, huge. That's our biggest battle here at Mahaska Health, that's for sure. And that's one of the reasons why, it was great to have Stroudwater come in and have Amy and Ryan just come in and drill down for us, because we knew, obviously, looking at the numbers, that denials management was a big piece for us. But to have someone come in and say, yes, you're correct, and these are the things that maybe you should start looking into, meaning you need to start looking at your registration. Are patients being registered accurately? Do you have the right insurance? Do you have the right demographics? All of those pieces play into that. So I could not agree more with that poll. Staffing, I think, will always and forever be an issue, especially for our rural healthcare settings. It's hard to get people out of the big cities, but for us, at least at Mahaska Health, I feel like our culture has been able to be our biggest selling point in having people want to be here. So again, I agree with the poll. That's my least concern right now is staffing. It's definitely those denials.
Sure. So when you were, rewind before you started working with Amy and Ryan,
Yeah.
what made you pick up the phone and call them? Or was it something where, CEO said, you must do this and call Stroud? What was it that made you call Amy and Ryan?
So that's a great question. So like I kind of alluded to in the beginning, we met Stroudwater, meaning Mahaska Health met Stroudwater back in 2019. We were struggling. We were really, really struggling back in 2019. And we were told Stroudwater was coming in. to see what was going on with Mahaska Health back then. And it was such an amazing experience to have them come in and say, okay, this is what's going on with your shop. A lot of us were very, very new here at Mahaska. As you could say, the house was cleaned and new people were brought in.
Mhm.
And part of that was having Stroudwater come in and say, hey, you need to do X, Y, and Z. Like, you need to increase your swing bed days. That's great for rural healthcare, critical access hospitals. You need to start using your swing beds. So 2019, Stroudwater came in, did a great job with us. Took us honestly from being where we needed a lot of help to, okay, now we're on the right track. So our CEO decided that 2024 we needed Stroudwater to come back in and take us from good to great. We knew we were doing all of the right things based on what Stroudwater had told us back in 2019. So our CEO brought them in as an overall assessment to Mahaska Health, not just the revenue cycle. But when I heard they were coming, I said, can I please get a revenue cycle assessment? I would love to know what we could do better than what we were doing before. And then we also had them had you guys come in and do an oncology assessment too. Oncology in our part of the state is very few and far between, and that's something that we're definitely looking at as providing more of a service to southeastern Iowa. So yeah, we asked for all three of those and we got them. So it's been great.
Awesome. Amy and Ryan, can you give us a bit of an overview as to, what an assessment looks like? I think that, there's the situation of here are the folks at Mahaska, they've already gone from good to really good, and then you're going to take them to great. But not everyone's in that same,
Yeah.
position. Tell us a little bit about what goes into an assessment.
It really started with just a series of questions so that it was like, okay, Kendall, how do you feel? Where do you feel your pain points are? And like we hear with a lot of areas, it's like, oh, denials are a problem. But we also might have some challenges on the front end. And so we asked with that. And then it was from there, it led to, that chart that I shared in the beginning where we just started at the beginning and just started asking questions. And then we said, okay, we've got these questions. You've given us some data, like, do you have KPI reports? Can you give us some aging reports and things like that? And then we just came into town, set up a date for Ryan and I to come and visit. So we came to Mahaska and Kendall got her whole team around the table and we just started firing off questions. And it was so much fun. I mean, I really enjoyed it. Ryan, you can give your insight into it as well. That we were talking, it's like we were talking to our people. I love to be a part of Stroudwater, but it's a lot of fun when we talk people who understand the denials. When we talk as fast as we do, I don't really notice that, JD, but I talk fast. So, and everybody I talk to talks fast. And then we get way down into the details, but then we pull it back and get at a high level as well. I mean, Ryan, what were your thoughts on that?
Yeah, I mean, I think you hit the nail on the head. It is a combination of that. Okay, we can look at the reporting and the functionality that you have in place and kind of that quantitative aspect, but going on site and having that face-to-face and interviewing and talking with each of those staff members and kind of getting that feel of what's really going on a day-to-day basis is really beneficial. And I think, the assessment is really our opportunity to help those folks that are not in revenue cycle, like JD mentioned. You're speaking these words I don't know. It's how do we tell that story of what's going on and the numbers that are being passed to the financial team or whatever. They say, okay, what is this? I know what bad debt means, but what's really going on in your world, and how do you interpret that and make that meaningful, and again, tell that story of what's really occurring in revenue cycle, so we can find out those areas that need to be tweaked. If you're going from good to great, like Kendall mentioned, that we need to maybe press the thumb here or pull a lever here to kind of improve things just slightly.
And
Yeah,
that I was going to say, and JD, part of what we do too is that we're bringing in those best practices. We're like, well, have you thought about doing this? And it was like, oh, never thought about that. And it's, but then they would ask us questions like, well, we're looking at this. And it's like, oh, that's pretty cool, identifying those things as well, that then we just share with everyone. And it's part of the reason why I was like, hey, Kendall, you're in a critical access hospital, 25 beds, right? Because we talk, I get in these meetings, they're like, well, we're a small critical access hospital with 25 beds. That's all I work with. It's like that. That's all Stroudwater does. We're in that rural community. but then to say, you're not with the huge I run into mega systems all the time, and it's like, you know, understand my challenges. And that was what is a lot of fun about doing a revenue cycle assessment as well.
Sure. No, I mean, I love the passion that you all have. I mean, both on the client side and on the consultant side, for this work. I am already lost in the things that you talked about, but that's okay, because hopefully the folks that are listening in are, the majority of those folks are connected to revenue cycle. So I want to go back to Kendall and ask a question, and I'm going to ask you to wear two different hats in this. So from a client perspective, I'd love your thoughts on kind of what it's like going through this. But the second hat, so here's the caveat, you sit in an executive seat, right? You're part of the senior team delivering these things, but you've got other folks that are working underneath you that are doing a lot of this day to day. And oftentimes I've found in my practice, when consultants come on site, sometimes the folks that aren't at the executive level get a little nervous. What's going on? What does this mean for me? Are they coming to find something wrong that I did? And those kinds of things. So I'd love your perspective on what the process was like, both from your seat, as well as maybe the perspective of the folks that sit alongside of you.
Great question. Honestly, the culture here at Mahaska Health is a little bit different. We like to say we're weird. We honestly, we're here to serve our patients. We're here to serve each other. And that's a big part of who we are. So when you ask about, the executive level and having Stroudwater come in, because we were already familiar with Stroudwater and we knew what they had done for us back in 2019. We wouldn't be here today. I think I can honestly say that we wouldn't be here today without that assessment, Stroudwater coming in and saying, hey, Mahaska, you need to do these three things if you're going to keep your doors open for your, town. And so I think that's the biggest thing is we already saw the great things at the executive level that Stroudwater did. So having Stroudwater come back in, 5 years later, it was an excitement for us, especially me, because we don't see anything punitive when it comes to someone giving feedback on what you could do better. We want to be here tomorrow. We want to be here in 100 years to be able to serve southeastern Iowa. So if someone coming in and saying, hey, you're doing this wrong, or you could do this differently, we're open ears. And that's kind of the entire attitude of the organization. So coming in and having these different assessments done, it's a breath of fresh air for us because we know that when Stroudwater walks away after giving us the tools that we need to stay open, once we follow those steps, we know we're, again, good to great is truly where we're at. So the CEO here at Mahaska speaks volumes of the Stroudwater team, and Eric Shell, that's there. I think they're on speed dial with each other a lot of the time.
Okay,
But
hopefully the recording can pause there. We don't need to inflate Eric's ego any further than it already is.
He's a Penn Stater though, which is really unfortunate.
That's okay. I'm gonna try to stay professional on this.
Hey team, sorry JD to interrupt.
Yeah,
It's
please.
Hillary. We just did have one hand up. I believe it was Richard had a question. If you would like to unmute yourself, and we have another raised hand, Susan.
Or I was
if you'd
going to
like
say,
to either, go
go
ahead,
ahead.
Amy.
I was going to say you can put your questions in the chat box or in the Q&A box if you would like, and we can answer your questions there, because I think, Hillary, you had already answered one of them as part of that.
Yes. So I will answer the questions if I can, or I will let you guys know.
Okay, perfect.
Sweet.
Awesome. So Kendall, before the on-site assessment began, did you or your staff have any concerns about that process?
No, not about the process. We were able to email with Amy and Ryan quite a bit to know exactly what information they needed from us to be able to kind of do some preliminary work, which was nice to go ahead and, you know, kind of let them see what's going on here, kind of what they're getting themselves into. They could, you know, we pretty much knew where we needed a lot of the help, and then just sending that off to them, they were able to kind of reiterate that, you know, yes, these definitely are the areas that need to be touched on.
Sure. No, it's a huge, I mean, I think in all practices, in, you know, everything that our clients are doing, data is the key, right? Without information or without data, we can't create information. Without information, we can't make decisions. And so being able to get on site, having that under our belts already is certainly important. But it's good to know that there weren't kind of concerns from your side relative to that visit. I guess from the three of you, what happened as a result of the visit? You know, how did we, first of all, did we go from good to great, or is that still a work in progress? You know, where are we now? What was the outcome?
Kendall, I'll let you go first and share it from your perspective if you want.
We're still going from good to great. We're just about 3 months post Amy and Ryan being here, so we have our little Bible here that they've given us that we definitely are working our way through. You know, it was nice to hear that we do a lot of upfront collections, meaning when those patients check in for visits, you know, we're trying to collect those copays and deductibles. For patients that maybe have high dollar services, like an MRI or a surgery, we're doing pre-estimates, trying to collect on those. And then, of course, outstanding balances. So, you know, it was great to have Amy and Ryan come in and kind of see that process on how we're doing that. And to give us, you know, some more options on, you know, where maybe we can collect that money. You know, they told us that our prior authorization team was spot on. That was a green dot, and that was really exciting for us. That was a brand new department for me to add on to revenue cycle that had previously lived under the clinic through care coordinators who were trying to do 10 other things along with prior authorizations. And as part of the rev cycle, we all know prior authorizations can make or break your revenue. You know, anything to give an insurance company the option to deny a claim. So we were really excited to you know, have our lead on from the prior authorization team and to walk through that process and be told, you know, you're doing exactly what needs to happen. We were able to create a KPI, or key performance indicator, which was awesome. Ryan and Amy gave us this great tool on basically an Excel spreadsheet to where we can just plug in our numbers every single month and be able to watch that trending. And as part of that, we're meeting as a rev cycle team once a week. So I have my scheduling director. I have our registration director, patient accounts director, and then I have a coding lead. And we all meet then once a week at the beginning of every month and the end of every month. We're looking at that KPI to see where we've landed or where we're headed, and to where we need to drill down on different parts of that KPI and what we're tracking. And then honestly, just going back to that denials management, I think we're all speaking the same language when it comes to that. Amy and Ryan gave us some ideas on how to look at those denials a little bit differently. You know, we always kind of look at it by payer or by denial itself, but you know, they recommended, hey, have you drilled down by provider? And that was something that we hadn't done yet. You know, we kind of knew what Blue Cross would deny for. We kind of knew what United would deny, you know, those type of things. But to drill down per provider, and then that's where we are tweaking those providers' habits and ordering things and things like that.
Sure.
Yeah.
Yeah. Amy, Ryan, anything to add there?
I mean,
Right. And
I will say, just from like I said, what was it, kind of the outcome or what's from there? Like I would say, yes, the assessment is done, but what we have still going on is a relationship with Mahaska. I feel like if Kendall has any type of question or need, she feels comfortable, and Amy and I are happy to be a support mechanism for her. And similarly, if we have another client within Iowa that has an issue, Kendall is more than happy to kind of share her insights to a particular payer. So I think one of the outcomes is you've got a friend in the business in that area that's around that again speaks that language that you can both lean on moving forward. It's not just a one and done and we're off into the night, but we're still continue to be there for Mahaska moving forward.
I think
Sure.
for me, there were about 3 key takeaways that really I took away from it. The one was, Kendall, you and your team, the shock on your face when I'm like, do you have any challenges with provider credentialing? And you're like, no, we don't have any. And I'm like, well, other people do, and you all were just shocked. It's like, I think there may be some people on the phone going, how do you, how is that shocking to you that you don't have provider credentialing? And that was just part of your processes that you've got in place that were so good. And we could bring it and go, well, do you not have these challenges? And you're like, nope, our people work on it. We've got a process developed. But then also, what I was, when you were like, well, we're good and we're working toward great, I'm like, but look at the results you've already put in place. Because JD, one of the things that they've done is they've developed cash goals for each of their front end people. That was a recommendation we gave you. And I'm like, you're like, well, it wasn't that there were 3 months past. And I'm like, wow, you all have been able to achieve a lot in that 3 months just by setting those cash goals by employee, by team, and what you were able to do. It was like, that's really cool about that. And then the other one that I thought was just, Brian, I think you brought up the idea when we were talking about it was, you have employees who are working and with the activities that your team was doing, it's like, well, do you know if they're working on the good stuff? Like, what is the stuff that they are working on? If they've got to hit 50 widgets in a day, do they hit 50 widgets that are just check the box and done? Or do they hit 50 widgets that 3 months from now we can come back and say, yes, those activities yielded good results? And it just, we were talking things that, we all understood. Like, JD, you're like, what? Happy to share that with you. But, it's, that's what I really enjoyed about the process, was to be able to say, you're not alone, but wow, look what you're doing. And then to also commend you, Kendall, and the team for, the things that since that you've been able to do and take it to that next level.
Yeah,
Hey, Amy,
and to go along with that. Go
oh,
ahead.
sorry, guys, it's Hillary. We just had a question in the Q&A for Kendall. And this is from Marjorie, and she's saying, Kendall, what approach did you take to get the providers on board with what to order to help prevent denials? We constantly have the pushback that they will order what they want, regardless of payment or denial.
We all laugh because that's true. You're not alone. You're not alone.
Two things on that. Number one, we have some provider champions here at Mahaska. Some providers that sit and listen to us, that are in a lot of meetings. Those providers are great advocates for us to basically speak provider to provider about things that tend to resonate a little bit different than if it's not a provider. And number two, dollars. We showed them dollars. Every time you order this lab, and it's denied because it's vitamin D, and the patient hasn't been diagnosed with vitamin D deficiency, so this isn't going to get paid. I know you all understand.
Yeah.
We'd show them dollars, and not just dollars as a group, but we would show them how much we've written off per provider. We would show their names. We would show that in a group of their peers. We would show that in front of leadership. and not necessarily to be punitive, because we understand that sometimes things do need to be ordered that an insurance company does not agree with. But the majority of the time, the rules are set for a reason. So we found that those are the two biggest ways to kind of sway. And I'm not saying that we don't also have providers that will say and do that as well. But the overall majority will see the dollars that are being lost, because, you know, they want Mahaska Health to be here tomorrow just as much as we do. So dollars speak volumes. That's a great question.
Yeah, and I would say, building from that and kind of what was an outcome of the assessment, I think you guys already had a lot of that data-driven culture in place. But after the assessment, I think we just kind of compounded on that, you know, making decisions based on the data. And like you said, going back to the provider and saying, this is what it's costing on an annualized basis. You know, can we justify this? Can we change how you document things? Or is there another option to XYZ that is payable per the policy? You know, kind of completing that feedback loop to the providers using, you know, hard numbers and real data really goes a long way, as opposed to you're making mistakes, we're not getting paid. I think the next step, logically, if I'm that physician, I'm in those shoes, is, well, show me how much, what's it costing us? What, you know, what are my options?
No, I think that's a great point. And so as we think about the outcomes of the assessment, being the non-revenue cycle person, and I'm guessing maybe out of the 200, 300 people that are on this call, there may be another person that's saying like, okay, those are a lot of words talking about a lot of things. How can I boil that down to what might make sense for me? I came up with 6 key things in terms of the outcomes. One, love the idea of the green dots. Right? What are those things that we're already doing really well, right? Make sure we acknowledge the world is not falling. Well, maybe it is, but you know, our organization is not falling down around us. We are doing some things really well. Is there an opportunity to do better? Absolutely. But let's celebrate success. We've got these green dots. We've developed tools. And when I say we, this is really agnostic as to whether or not it's Stroudwater or it's Mahaska or it's any organization out there, you know, coming out with an assessment where you develop tools that can be used into the future. That's a really important thing. Changing a meeting cadence, not meetings for the purpose of just having meetings, but meetings with a purpose, you know, gathering your team together now on a weekly basis so we can address some of these things. Coming up with some new ideas, you know, the idea of looking at denials by provider as opposed to just denials in general. If someone can take from this call that as an idea, I think that's a good thing. I'm a huge fan of public shaming, right? If it's one doctor or, you know, inside of Stroudwater, you know, if someone's not submitting their materials on time, you know, I'm a big fan of putting their name up in the coffee room and saying, you know, hey, Downs didn't deliver his thing yet again. Kendall mentioned focus, right? Not just saying here are 4, it may have actually been Amy that was saying, not just here are 4,000 things to do, but what are the 4 things of those 4,000 that are most important, that are going to get us where we have to go? I think that applies outside of revenue cycle. It applies to everything. Oftentimes, the more data we get, the more paralysis we get with the analysis. And so if we can narrow down, solve these 5 things, and that's going to be most important, that's super important. And then finally, and I hope that, you know, Kendall doesn't get a massive influx into her email or phone, but I'm sure she'll accept them, the connecting peers to peers, right? It's a lot easier. And I think that worked the same way with your provider champions, right? It's a lot easier if someone that sits in your same chair in a different building, if they've done it before and you can talk to them, that's a lot better than calling up some consultant that wants to sell you something. No offense, Stroudwater folks, but you know, peer-to-peer conversations are what these events are designed to pull together. So, you know, kudos to all of you for doing that. I think we talked about some of the changes already that were implemented as part of the assessment and the recommendations. Is there anything else that we want to talk about, things that you've done differently, Kendall, out at Mahaska?
Oh, I'm trying to pick my brain on what else we've done. One big piece we did that we're still kind of in the throes of is for our registration team. So as a part of the overall assessment, that collecting money up front is huge and critical, especially in small organizations like we're in, because it's something like $7 a statement. If you put everything together on how much it is to send out a statement to try to get that $10 copay, or that $20 copay, or even just those small dollars, not to mention thousands and thousands now that we have the high deductible plans. We created a registration incentive for our team. So all of our registrars here at Mahaska, and I believe I have 27. I have 27 in total registrars at Mahaska. And each of them, as part of their annual review, has a goal. So depending on where they're checking in here at Mahaska, they have different goals. So as part of our medical group, some of our registrars at a certain door, their monthly goal is to collect $12,000. And again, that's the copays, that's deductibles, that's outstanding monies that are due to Mahaska, and also those upfront collections, those pre-estimates for those large dollar services, all the way down to my PRN registration staff. Theirs is $1,000. So those are set ahead of time to reach those goals. If they meet the goal of our goal for 2024 was monthly to collect $100,000 total. We've bumped that up to $150,000 starting in 2025. But the incentive we've given them starting January is that if they could collect, each one of them individually could collect 150% of their monthly goal, we would give them $1,000. And at the end of the first month, I had 7 that collected it. So, that extra $7,000, believe it or not, brought in an extra $21,000 to Mahaska at that front end. So that was a recommendation at Stroudwater. Make it fun, make it they had that goal of all together, let's get 100,000 or 150,000. And that was a pizza party. But now it's, if you can collect that 150% of your goal, you get an extra $1,000. And for those, at the front end of the revenue cycle who make, maybe $16, $17 an hour, $1,000 is huge to anybody. I don't care who you
Huge.
are.
Absolutely. That's amazing.
Yeah, so the last 2 months, it's been outstanding. They've met their goals of 150,000 plus on top of that. And I was able to let the board of trustees know this as well. And of course, I got the backing of our CFO and CEO before I pulled these triggers. But no, knock on wood, so far it's gone fantastic, and we're just gonna keep going, and we'll change honestly organically if this starts to slow down, or we need to go a different direction, or maybe apply this to other areas of the revenue cycle we're looking at too. So, if you can put, I would give that $7,000 for 21,000 every single day. So
Yeah, absolutely. So
Team,
I'm going to pause. I was
oh.
going to ask that question, Hillary. I'm gonna pause just because there's a question that came up quite timely in response to Kendall's discussion. How are you collecting copays? If an insurance card doesn't indicate a copay anymore, patients don't understand it, and it's like, wait, what do you mean I have to give you X? How are you all dealing with that? And then I'd like you to call my primary care office so that you can explain it to them.
Oh, great question. I feel like we're all on the same team. We're all living the same parallel lives right now. When I joined Mahaska Health, like back in 2018, $0 were collected at the front end. You walked in, you weren't expected to pay your bill. Over time, it's taken us some time to change the mindset of the community. So that's a big piece of it. They know when they come to Mahaska Health, they're going to be asked up front for money, especially with those high dollar services. I'll just start with those real quick. Those high dollar services. So I have a person in our patient accounts department who works a work queue to where those large dollar services fall into. So if, you know, a case request has gone in for, say, an appendectomy or a total hip or a total knee or anything that's planned, or again, high dollar radiology is another one, PET scans, MRIs, those fall into a work queue for that person to then run the benefits, find out how much deductible, if there's a co-insurance, what the out-of-pocket maximum is. They're calling those patients and saying, hey, you know, Mrs. Smith, you're having an MRI next week. Looks like you have a high deductible plan of $5,000. You know, we request that payment up front and then kind of work it from there. We also send them a letter. So they're hearing it a couple of times before they walk in. So even if they can't pay the full amount of, let's say, $5,000, they're paying something. You know, even if it's $50 as a critical access hospital, if we collect $50 up front, I feel like that's a win. It's $50 more than we hadn't before. As far as those copays that aren't on the cards, when we run eligibility through our electronic health record, it comes back to tell us 9 times out of 10. Of course, there's a few out there that don't, but 9 times out of 10, that eligibility run is telling us what the copay is. So, and it's a conversation we just have. You know, it's basically a contract between, you know, you and your insurance company that you're going to pay us the $20 when you come in for, you know, your office visit. So education, education, education is what it is.
Sure. And you're on Epic, is that correct?
Yeah, we're an
Okay.
Epic Community Connect. So we don't get the big voluminous Epic.
Sure.
We get it through a facility up in Des Moines, a large facility up in Des Moines that we're able to hop on them. And a lot of critical access hospitals here within the state of Iowa are either on that Epic out of Des Moines or one out of the university at Iowa City. So that's how we can afford Epic.
Awesome. So another question, just as from a facilitation perspective, as opposed to reading through a series of questions that are popping up in the Q&A, which we will, for those folks that are writing things in the Q&A, some of them we will get to throughout the course of the presentations. If we don't get to it through the course of the presentation, we will absolutely follow up with an answer to you. And we should have some time as we get towards through this presentation. But you mentioned, Kendall, you know, that Kevin, the CEO, you know, has kind of got a big personality, and you know has, you know, he calls Eric Shell whenever he has a question. But how do you ensure leadership buy-in for all the things that you're looking to do? You mentioned the CFO. You know, hey, better check with them before we're giving $1,000 out to our registrar, our front end folks, each time that they meet this goal. How do you get that buy-in?
Yeah, and it's the culture. It's the culture that our CEO set when he also joined in 2018. Transparency, communication. We all get in a room once a week for 4 hours as an executive team, and we have a lot of crucial conversations. But it's a very safe place to do that. We're an independent critical access hospital. We are not at least in the state of Iowa, we're not a Unity Point Health or a Mercy or a university. We're Mahaska Health. We are who we are. And for us, that's been critical, to not have, you know, 7 different layers to go through to be able to make those decisions. We trust each other. And our CEO trusts the leadership, kind of let the experts do what the experts do. You know, we've all been doing what we're doing for a very, very long time. And we're all here for the same reason. So and honestly, this is the first place that I've ever been that has that kind of an attitude. You know, I've been a part of 80s management styles. I've been a part of that. I've been a part of a dictatorship type leadership. I think we all have, and I think we all learn a lot from that. You know, we go through that, and I think we learn a lot, and our takeaways are that we had to go through that for a reason. But to come out on the other side of things, and to be in an organization that truly, again, just wants to serve the community, has been a breath of fresh air. And it just kind of, it's like that all over the facility. It's very cliche that I say things like that. And when I interview different, applicants, those are the people I'm looking for. You know, I'm not looking for someone to come in and who knows it all and who's gonna, take over the world. And that's kind of how all leadership has been here at Mahaska. So just a little bit different.
Sure. How long did it take to implement these changes? From, once you did the assessment, came up with some recommendations, understanding that everything is ongoing, right? It's continuous evolution. But how long is the rollout process to start seeing results?
So if Ryan and Amy left at 3:30, 3:31 is when we started implementing. No, honestly, um, uh, when when before they even came, they were already providing me with pieces of information that I didn't have. One was the KPI, that key performance indicator. We have dashboards as part of our electronic health records. We look at them every day. We make decisions based off of that. But this was a different kind of tool for us to use. So honestly, before they even came, we were working on those KPIs for sure, and meeting weekly. But then once, Amy and Ryan came and they gave us that information, honestly, it was basically same day. I mean, we as a team met with them all together all the time. We didn't break up. We were just, I wanted my registration director to hear what the patient accounts director heard. And that was a big piece of it. So we were all on the same page. So honestly, when Ryan and Amy walked out the door, we already knew what we wanted to do just because we'd made the decisions when they were here. It was best practice. It made sense. We knew that it would be monumental for us. So, right away. But over time, we're still, we meet every week. We have those conversations. We continue to work through, the Bible that we were given, and are just continue to make those changes. So.
Yeah, I have a small note just about Amy and Ryan leaving at 3:30. I'm not sure why they're not working a full day, but we'll talk about that later on. Hopefully.
AM. I kept them to the morning.
Oh, well, there we go. Then that's perfect. Then, as any good consultant, I hope that they kept the meter running. In terms of measure, I mean, I think we've really gotten a lot of this already, but in terms of measurable outcomes that you've seen, I mean, we've got our front end registrars meeting target goals or exceeding target goals and getting individual incentives for that. We've got pizza parties for group incentives. We've got presumably changes to provider behaviors in terms of some of their ordering practices and the claims denials that come along with the lack of those changes. Anything else that you would say, here are, 3 fantastic measurable outcomes we've seen at Mahaska since we did the assessment? And it's not just an assessment, and it's an assessment with some recommendations for change. It's one thing to look at what things are. It's another thing to understand how they could be different, what it might mean. What has it meant?
Oh, goodness. On top of everything we've already discussed, let me think here. Billing, I haven't touched much on the billing piece of it. For the denials management, we did end up reaching out to a third party because we knew that our denials had gotten to where we wouldn't be able to basically drill those down with the team that we had. And it didn't make sense to hire more team members. Our billers are broken up by payer. So, you know, we have the Blue Cross, we have commercial, we have Medicare, Medicaid. They're broken up that way. And so we, like I said, we did reach out to a third party to help us with that. We're talking about incentives for those billers, kind of like we have for the registrars, once we get that squared away. When we talk about, you know, trying to find those applicants that are good fits for the organization, one that it's really hard to find billers who have the passion to capture the money. So we that's one thing that we're definitely working on, continue to work on. And then, gosh, that's really all I can think of.
Sure. No, that's fantastic. So Amy, there are a bunch of questions that have popped up in the chat box as we've gone through. Some of these we've answered, some of them because I am not a revenue cycle professional. I don't even understand the question in some of the cases. What do you think is the best use of our time at the moment? Do we want to answer some of those questions before we go into Ryan's presentation? Do we want to do those at the end? What is best from your perspective? You're on mute still. Slight operator error.
Yeah, that was the problem on this side of the table here. So I was looking at some of the questions. Some of the questions we might be able to answer just because they're quick answers. Others may be a little more involved, and we'll have to get back to you. One of the things I think I can go through and ask some of the quick ones to you, Kendall, because a lot of them are just short, quick answers.
Sure.
What eligibility software do you use? And you're on Epic, so we've said that. But what eligibility software?
Yeah, it's actually embedded within our clearinghouse. So our clearinghouse that we're required to use through our Epic is called Olive Lighthouse. We are switching to Experian here later this summer, but that's where all of our eligibility runs through. So it's nothing we've added on.
And do you do batch eligibility?
Yes.
Okay, so you are doing batch eligibility.
Yep, we do.
Okay, all right. And Epic does power the eligibility tool, so I think we just answered
Yep.
that one live.
Yep.
And then, do you have union employees?
Yes.
No. Okay. Then the third party for denials, have you signed that agreement? And I don't know, perhaps we'll get back to you on that one because I don't like to keep it fair and not really highlight. So
Won't give the name. We have signed. They start today.
Okay. So more to come on that one then.
Yes.
And then I think some of these others, they might be a little harder. How do you engage the providers to schedule those high dollar tests in the future in order to attempt to contact the patient? We're a small practice and our providers use the convenience approach with placing orders for patients. Since they're here, let's just go ahead and do the MRI.
Well, most of those require prior authorizations. So again, it's just been a lot of education to the providers and just kind of, I hate to say beating that into everybody, but you know, you have to give us 7 days. That's what we ask for prior authorization, even if it's Medicare, because we want to make sure that even though Medicare doesn't require prior authorization, they have a lot of LCDs and NCDs that say this is the criteria that has to be met. So we also check medical necessity. So it's, again, give us that 7 days. You know, we understand that it might be an inconvenience to the patient. And if it's emergent, we'll send that patient through the emergency room. You know, that doesn't require PAs. We'll go that route. But it's just communication and again, showing them the dollars that could be lost.
And that 120% of that cash pay, so different subject, back to the cash collections target. The goal that you based the 120% of, I know I looked at that report, it's by employee, is it not employee and
Yeah.
shift?
Yep. So it's actually 150% in order to get the $1,000. But so basically we've looked at those positions in the past and what they've collected. So if it's Amy and Ryan know that we have a lot of doors here at Mahaska. So depending on what service you're having done here, you may come in a different door. So door 4 is our medical group. So if you're coming in to, see one of our primary care physicians or providers, it's in the medical groups. You're coming in door 4. And we have a couple of seats that we call the hot seat. So when you walk in door 4, it's like, those are the registrars you see. Those are the ones that year after year have collected thousands and thousands of dollars. So we've kind of taken historical data from those registrar seats, and kind of put that into the formula that we use today. So we kind of know where people are at. It wouldn't be fair for, say, the emergency department registrar to have to meet $12,000. We have to be careful with EMTALA. We're collecting on the way out. So, theirs is a lot lower. If you think of, someone working 9 to 5 at the ED window versus someone working 7 to 7 at the ED window, so it's really just kind of looked at how those seats have done in the past, and then just kind of set those goals for those registrars, and it seems to be working.
Okay, perfect.
Awesome. Thanks so much, Kendall. It's been wonderful from my perspective to learn as a non-revenue cycle professional all of the things that you've done at Mahaska and that Amy and Ryan have been able to help with. I think what we'll do at this point, top of the hour, is transition to a presentation that Ryan's going to give, kind of optimizing some of that front end can't even get English out, optimizing some of the front end operations. I know that that's, a big piece of what we've been talking about. So whether it's Amy or it's Brian, oh, no, it's Ryan. Good. So Ryan, I'm going to kick it over to you. I'm going to drop onto mute and turn my camera off for a moment, but I'll be here listening and learning with the rest of folks. Thanks all very much. Ryan, you're up, Doctor.
Awesome. Thank you.
And
Go
I
ahead,
believe
Amy.
we have a poll question. So Hillary, because I'm sharing my screen, I can get to the poll. I believe that if we go back, we have a poll question. There we go. So which front end improvement would have the biggest impact on your organization? Optimizing scheduling and pre-registration, strengthening insurance verification, reducing claim rejections up front, enhancing patient communication and education. We'll give everyone a few minutes to answer, or a few seconds to answer this. And then also we will be sharing the Q&A, the questions that have come up. So continue to put your questions in the Q&A box, even though we haven't been able to address them on the call. We will answer them, get that sent out to everyone, as well as a copy of the presentation slides I showed earlier. It's also under the resource tab if you wanted to see what we consider to be revenue cycle, and then this deck that we are sharing right now, as well as the recording, will be shared with everyone. So with that, I'm going to end the poll now. And it's interesting. Oh, did I share the results? Here are the results. So you will see that the highest winner here is strengthening insurance verification process. I agree with that. That front end improvement with the reducing claim rejections and optimizing scheduling and pre-registration. So with that, then Ryan, I'm going to hand it back over to you and let you chat.
Yeah, awesome. Thanks, Amy. So good morning. Like mentioned before, I am Ryan Brenneman, and I will be sharing some of the things in the front end revenue cycle practices. Just so you're aware, Amy and I do a lot of presentations and work together pretty consistently. So she may jump in or jump out at any given time. So, don't be surprised if she cuts me off at any time. I'm totally used to it. It doesn't impact me or upset me whatsoever. But again, what we will be talking today is really those front-end practices, that set your revenue cycle up for success, really give you that highest probability to keep your patients happy, informed, and hopefully collect some of that money at the beginning of this process. So if we move on to the next slide, Amy, what we do see as we get there. There we go. Is that overall claim lifecycle process. This is the same slide that Amy was showing earlier. We do have those those front end and back end processes here again, somewhat bookend by those pre-claim and analytics activities. But really what I'm going to be covering is those in that kind of orangey, whatever color that is. I'm a little bit colorblind, but those in that pre-visit and visit portion that are highlighted. Within that pre-visit column of revenue cycle, we're focusing on items, that we can complete and confirm prior to the patient actually coming into your organization or into the hospital, before that first patient face-to-face interaction even occurs. I will say it's worth calling out and emphasizing that good revenue cycle practices do begin actually before that patient is even seen. These pre-visit functions are those that help set your tone for the visit. They ensure that you're getting that proper information on the front end. You've already gathered it, and hopefully you're giving that patient some ease and some comfort that will allow for an overall productive experience once they do visit. Amy will talk about denial management a little bit later, but really the actions that we're doing here in pre-visit and in that visit do have a significant impact on your ability to collect and what your potential denial rate may be. So again, take that time to get things right on the front end, establish your standard of work, establish those expectations, and try to reduce those missteps that will become more costly and more difficult to correct later on through the revenue cycle process. So with that, if we go to the next slide, Amy will start with just some, I say, things to remember and best practices around your scheduling and pre-registration. Number one is to put that patient at the heart of the revenue cycle process. Efficient and compassionate scheduling and registration do, again, set that patient at ease for the entire visit and help things to run smoothly. I'm sure probably everyone on this call has probably had some positive experiences going to a doctor or a hospital or to an urgent care that's like, man, they've got their things together. But then probably even more likely is that you've been someplace that left that bad taste in your mouth. So again, try to put yourself in that patient's shoes and really take that extra time on the front end to consider what would make that patient more comfortable and knowledgeable about what is to come within the process. Your scheduling and registration staff may also be the first interaction that patient has ever had with your organization. So this is that opportunity to get that relationship off on the right foot. So we would want to encourage your staff to act as an agent for patient satisfaction. Build that positive tone from the get-go. Make that first impression count even in that scheduling and pre-registration process. In the top right corner, we see that we're there to help set that tone by providing scripts for your staff to follow. This does allow you to have some consistent, I'd say high quality customer service. One of the ideas we kind of take from Lean Six Sigma is to eliminate variations in your process. So if your staff does know what to say, they know how to begin that conversation in a positive manner. We're not looking to make it robotic or cold, but we do want to keep that conversation on the rails and let them know beforehand, this is the likely next step that I'm going to take within this conversation and that pre-scheduling process. As we move to the bottom left here, creating a pre-registration process to improve and address those non-covered services. Again, this really ties into that streamlining of a process within Six Sigma. We want to eliminate those variations, or really more so here, knowing what to do when those variations do occur. It's I'd say kind of like developing a flow chart or having a process in place so that you have it, either physically or mentally, that when your registration or scheduling process is interrupted or there's a new variable, how will my team handle that and react and adjust accordingly? Very similar to this in that bottom box is standardizing your data. Again, are we eliminating all the variation possible, especially in the data that you're receiving potentially from referring physicians? Can we make that process smoother and easier to follow and get more reliable service and coverage for your patients? Is it possible to get your referral data in that registration data in the same kind of text and same format with the same data elements located on the same places within the paper? Again, make it easier for that staff to find the information, not make mistakes, and get everything as clean and clear as possible on the front end. And then I'd say finally here on this slide is centralizing scheduling so that patients have one place to schedule service or get their information. You may want to help the patient be as informed as possible and try to remove as many barriers as you possibly can that potentially could cause confusion or disjointed messaging or something along those lines. I would say that confused patients likely probably give you less accurate information, and that those you want to know exactly where you're getting that information and what they're expecting to provide to you, and they get that same message across the board from everyone. With that, we kind of move on to the next slide, which does have a couple more best practices. So number one here, develop a process to ensure that your physician order is available at the time of scheduling. You don't want to know, who's ordering what test and essentially why. Having this information does help to eliminate any of those hiccups you may see or issues that may arise later that cause all those nasty denials. Again, we're looking for consistency, accuracy, and a formalized process to help employees to follow and then refer back to if necessary. Again, mentioned here, centralized scheduling kind of in that bottom left-hand box is another great idea. As you think about everything that we've talked about to this point, and along with our conversations with Mahaska, we want to eliminate patient dissatisfaction and really use that as one of our primary goals. Your front-end processes do help to eliminate those issues that we may see in denial management. It really is kind of like this flow chart, and if something breaks early in the process, it does have a significant impact to the back end. And then on the right here, pre-register patients by obtaining, patient demographics, insurance, employer information, maybe their preferred pharmacy, all that good and critical stuff that helps your overall process be streamlined. You also want to make sure that your staff is aware of any specific carrier number requirements or subscriber numbers, things like that that are very specific to your hospital or the type of insurances that you're seeing. For example, if the Anthem carrier in your area always starts with a 3-letter alpha prefix followed by 9 numerical numbers, your staff should know this. If they see something that doesn't meet that criteria, it should cause a red flag, and for them to stop and go, wait, okay, let me re-review this and make sure I'm not missing something, or this insurance is no longer valid. Again, you want to have that process in place and that there's a stop if something doesn't meet the normal criteria so that you can eliminate potential denials later on in the process. As we look at some of the pre-registration activities, we have covered those items that we can in pre-registration. So do as much as we can in that pre-register. And now potentially the patient is finally arriving at your doors. So again, many of those common strategies and goals of pre-registration are still present, when that patient is there for that check-in process. We are again looking to improve that patient experience, improve the workflow, reduce their wait times, and then in turn generate some higher patient satisfaction. This again is building upon the work that was done in pre-registration, and then also with your scheduling component. So as part of this registration, we also, I think we talked about it a little bit with Mahaska, is to recognize that vital importance that your registration team does have in preventing denials moving forward, as well as their importance in collecting cash. Accuracy in these areas, again, prevents future problems, reduces misfiled claims, uncompensated care, in turn can reduce your bad debt, and maybe even avoid some compliance risks. So again, we really see that effective registration is very critical for the success in your entire revenue cycle. Amy and I kind of often said that patient registration should not be used as the stepping stone to move to another area within the hospital. We really see these people that should be higher paid. They're a well-informed and critical piece of that revenue cycle. So these folks need to have insurance knowledge, customer service skills, ability to adapt to changing environments. So really, I would say take some time and consider if this role in your revenue cycle and in your organization is given the value and the appreciation that it really deserves, or if, quite honestly, you have folks coming in and then after 6 months in that registration area, they move off to another world and it's really just their introduction into your hospital. So on to the next slide. As we mentioned before, registration does help to set that tone for your patient visit. Hopefully this is a warm, friendly interaction, but I'm very keenly aware that that registration area gets hectic, busy, and kind of a very stressful area in some instances. But hopefully if pre-registration went well, we can kind of reduce and minimize some of those headaches and challenges that we do see in registration. The more effective that your pre-registration process was, the easier and smoother this registration should go. So again, think of this as somewhat of assembly line. The departments and actions that are occurring upstream have a significant impact on that final project. And those, if they're going well above stream, you'll have a better opportunity to be successful, kind of in that registration area. As mentioned before, we talked about kind of centralizing this for all patients, or in each ancillary department at least. And the amount of time this takes will vary based on, again, the success of those prior areas. But I would say if you're struggling in registration, it may be worth your while to review what's happening upstream. How is pre-registration going? How do your appointment reminders look? How are those things upstream doing? And are those causing your headaches and you're just feeling the aftermath here in registration? I would also say, this is your opportunity to complete that final paperwork, get consents or waivers, or any of that information that has not been reviewed or potentially has changed since pre-registration. Hopefully when the patient gets to this point, they have some idea of where they're heading next, what's going on, who they're going to see, and that they do feel comfortable with the overall process to this point, and that they know what's going on within your organization.
Ryan, when you think about that patient that's showing up for registration, they're coming to have a service done. I mean, they're not just showing up to the hospital because they want to hang out with us, and they've got other things on their mind. And so whatever we can do as an organization, to make that just as seamless as possible. It's one less thing they have to worry about. And I have to worry about how much cash they're going to pay and all of that. You take that burden off. It allows them to focus on what they're there for getting healthy, for being better. And it does improve that overall patient experience. And, it really starts that patient satisfaction. The rating of your hospital starts with these activities. And I think sometimes we tend to forget that they're there not just because they want to hang out with us. We're nice people and everything, but, but at the same time, they're there for another reason. So,
and I will say this is just not to cheer on Kendall or praise their success. She mentioned, well, we have multiple doors. If it's your first time going to Mahaska and you have I'm walking in a door, where am I going? Am I going to the registration, or am I going to walk into a boiler room? Like what's going on? I think that if you've set them up for success, they go, this is the door you go. It's door number 2. It's perfectly, it's noted, where you're going to go. This is what it's going to look like. All those things have answered prior to it. The patient walks in and they're in a better in a better situation to have a good experience and a positive experience than they immediately walk in. It's like, I'm already confused. I'm already nervous for what's occurring. Now it's just going to go downhill from there.
And it, they may be going door 2. They told me to show up at door 2. What does it mean, door 2? But when we got there, it was like big old
There's
numbers,
door 2,
and here's door 4. And it was like, oh, that makes perfect sense. And that's how they refer to it as. But it, we weren't there for a medical reason, but it did set that expectation of, we knew, well, this is where they told us to go. And we just kept going, and somebody found, it really works. And helping, to realize that we're not the back end of the process. We are probably the first point of the process that some patients may ever have experience with your facility. So.
Yep. No, that's great. If you want to click on to the next slide, Amy, we'll keep going. So just some registration best practices. Again, try to perform as much as possible prior to that day of visit. You want to be aware of any issues before they arrive, and try to work out any opportunity to insurance changes, address changes, whatever it may be prior to that day of service, so that you've got that taken care of already. Again, this helps to limit the amount of time the patient has to complete information the day of, probably puts them in a slightly better mood. Number two, we've mentioned maintaining similar processes as much as possible for inpatient, outpatient, and other departments. This is effective in eliminating that variation and providing that consistent service and getting more consistent data back from your patients. We also want to be sure, in that top right, that we are following EMTALA guidelines for those quick registrations that may occur in emergency rooms. So when possible, we are reviewing and confirming any additional information that has been gathered, but just recognizing that is a little bit different for that quick registration process. And then again, as mentioned throughout this presentation, that effective communication is important, both between you and the patient, as well as between internal departments within your hospital. Reviewing that information and knowing, for example, when an authorization is required, helps to lay that foundation for a successful registration and that day of visit, as well as we'll talk about here a little bit more even further, is broaching that subject of that patient financial responsibility, to the patient at that first day of service when they arrive. We could probably do an entire boot camp just on patient collections, but just to touch briefly, best practice is to at least begin that conversation, prior to service that same day, and not just send a bill and wait until the service is done. What we will see in a little bit, that may have worked 10 years ago. We are not in that environment, unfortunately, anymore with healthcare. So if we move on, just a couple questions to keep in mind. I think it's kind of a value to kind of go back to that elementary school mentality, that fact gathering of the 5 W's and how, try to be that news reporter, getting all that pertinent information. Who's going to arrive? What do they need to bring with them? Where are they going to go? Is it door number 1, door number 5? Exactly all that information. And I would say, these questions go both for you as the provider as well as the patient. You need that information from the patient to get that revenue cycle process rolling, to keep it moving in the right direction. And the patient needs that information so that they feel comfortable, they know what to expect, and how to make this entire process, again, as smooth as possible for both parties. If it's their first time visiting, they're probably confused, nervous, don't even know where to park. So again, try to take all that off of their plate and make it as calming and as effective as it can be for them. I would say, that the relationship between both of you is served best if everyone knows what's going on, everyone's transparent, everyone knows what's going to happen when that patient arrives. So again, just consider these questions and ask yourself if your current processes within registration at least answer all of these in some way, shape, or form for both you and the patient.
Ryan, it was interesting. I was talking to a friend of mine, and she was getting ready to go in for surgery. And she said, I don't know how much I've got to pay the hospital, but my doctor, he's told me how much I owe, and it's a lot of times we as the hospitals think, oh, we can't ask for the money, things like that. But, their doctor has, if they go to Walmart or Dollar Tree, that they're getting asked to pay for those services. And, it is a challenge, but those are the things that are, but at the same time, they're wondering, how much will this cost me? And so if you can, they're asking that question. They may not be asking you, but they're asking that question.
Yeah.
And
I think you've done a great, fantastic job to transition to the next slide, Amy, just for that conversation. And I'll kind of touch on it. So what we see here, this is a slide that's published by the Kaiser Family Foundation. And what it is it's showing the percentage of covered workers enrolled in a plan that has an annual deductible of $2,000 or more. All that to say, look at the lines, it's going up drastically year over year. So your patients have a higher percentage of them are going to have a deductible of at least $2,000 than ever before. We also know from several studies that most households in the US are not equipped to handle a $400 emergency. So again, we want to emphasize that importance of having that conversation on the front end and having that effective patient collection strategy. Like Amy mentioned, even if they don't come out and say, what's my bill, they're probably thinking about it. And I would say the more empathetic direction is to have that conversation up front than to shoot them a $6,000 bill or $500 bill or whatever it may be 3 months down the road. And they've honestly just been sitting at home festering and wondering, what is that bill going to look like this entire time, and not having any clue. So again, that transparency is very important. And again, more and more of your accounts receivables are probably falling into that patient responsibility now than ever before. So again, making that effort to start that conversation on the front end is, again, this is now a front end process. This is no longer a back end only process for collecting patient responsibilities. And we need to make that conversation begin as soon as we start seeing that patient. So kind of going hand in hand with that, given that we need to make that effort to collect on the front end, your insurance verification really becomes very important, because it becomes that first step of knowing, what do they actually even owe me? Doing that verification does not guarantee you're going to get payment either from the patient or the payer, but at least doing that verification can help make sure that you're checked that first box, meaning, did I even send this claim to the right person? Like if I bill Cigna for an Anthem patient, 100% you're not going to get paid. So at least we have to check that box so we can have an opportunity to be paid for what we are doing. You can see here that, overall, we are seeing the claim denials have been steadily growing year over year. And that's probably something that does not surprise anyone on this call. We have also seen reports, unfortunately, that some plans have denied up to 49% of the claims that they are receiving. I won't mention the names, but you can probably guess what type of plans that would be, whether it be, well, I will say Medicare Advantage or something else. But that's what we have seen in the environment. We're also seeing, unfortunately, and I don't want to be the bearer of bad news, but probably things you're fully aware of is that many of these denials are now being caused by, AI methods, payer automation, things of that nature. That's quite honestly being harder and harder to get that claim in the door. I will say though, we've looked at some research that indicates that 86% of these denials, are potentially avoidable. What that means is if you could at least start with the right, documentation and insurance verification and everything on the front end, you have an opportunity to be paid. And as it states here, the cost to work the denial is roughly $118 per claim. What does it cost you on the front end to spend a little extra time to do that verification and make sure that that insurance is correct? So again, our focus here is that proper insurance verification does streamline that claim process, and it helps that back end a little bit more to do it as much and as thoroughly as possibly we can do. And I'd say the last point here is that insurance verification uses all that information obtained from the scheduling and registration steps. So again, each subsequent step is kind of building and reliant on those pieces upstream. So insurance verification can be hindered by your registration techniques. So again, don't be afraid to ask those questions and dig into your insurance verification issues and see what is causing those headaches. Is it a byproduct of something that's occurring upstream? So with that, we will go into a couple of the best practices around insurance verification. Number one, verification should be run on all admissions, including your reference lab tests. Not verifying coverage on something is, again, an opportunity for that revenue to slip through your cracks. Number two, Kendall mentioned this, leveraging some online tools or a partner within this. Many of your systems do have their own verification opportunities, or you can use a third-party vendor that can do something in real time, or that batch methodology like Kendall mentioned. So again, it's good to look at all of these options and kind of leverage each of them as best as you can within your need. It is also a good idea to check your primary as well as your secondary and tertiary insurances if possible. I would say that this is probably a good opportunity if you're looking at building some AI or finding an AI partner. Your eligibility area is one of those that's probably one of the first in line to find some savings and some economies of scale there. Also here, with that rapid increase of your Advantage plans, one of the biggest, I'd say, insurance verification issues we have seen is something I call like, oh, we've got the insurance close, but not quite. So you think the patient has a Medicare, or they present a Medicare card, but they have the Advantage plan, or vice versa. So again, look at your eligibility options. There are some systems that will provide you that right information back. And can you pull that information from that system and repopulate it back into your EMR platform, et cetera? So again, keep that in mind as a best practice. Also, within your insurance verification, be aware that some of your self-pay patients may qualify for Medicaid or charity care, and your best practices here would be to have a policy and process around both of those situations so that you can identify them as early in the timeline as possible, and not wait until the patient gets a bill and they go, oh wait, by the way, I had Medicaid, and you have to start that process then, and you're kind of working from the back end back forward.
And I think, Ryan, you don't mention it here, but a lot of states that have the MCO plans, to know which one of your Medicaid MCOs that you need to be sending that bill for, because it could be you think they have straight Medicaid, but they actually they've signed up for one of the MCO plans, or last month they had this plan, this month they have that plan, because they can change every 30 days. And hello, thank you for giving us that additional challenge in revenue cycle.
Yeah. Yeah. I mean, and it's not directly on here as kind of a best practices, but I think the way that insurance verification is going is, 5 years ago, you just have someone potentially maybe just calling and checking verification. Now we do need that sort of, I'd say not IT person, but there needs to be at least an exploration of what are the opportunities within automating some of this process, all of this process, to provide that information back and get that feedback from those payers and kind of move down that pipeline. That is an area we're definitely moving. That, like you said, oh, they did sign up for a Medicaid MCO. Can we get that feedback from Experian or whomever it may be that provides that information, and that we can use that? So yeah, absolutely. I think that's a valid point here. Just to kind of go on, a couple other things we do see is the No Surprises Act. We could probably get into a lot of detail here, but just understand, do you have the opportunity to provide good faith estimates, notice consents for your uninsured or underinsured patients? Again, do you have those tools in place to provide that information to your patients in a timely manner and meet those requirements? Hand in hand with this, I'd say, be aware of those patient responsibilities. This is a growing percentage of your AR. So if you're doing that verification, can you get that information back that says patient owes this copay, and begin to have those conversations right then? And I would say kind of the last best practice here is to track your verification rate. Again, this is a reminder to have KPIs in place to monitor how successful you are in registration. Kendall talked about the successes that they've had in starting to monitor that and move forward. So, you want to be aware if items are slipping, if you're getting better and improving, and then what changes you're seeing in each of these areas. You jump on in, go ahead and. No, you're fine. So again, here we'll kind of jump into that prior auth piece and that prior auth best practices. Number one, develop a process that crosswalks your insurance plans, your CPT codes, and those requirements. It does make sense that your first step in prior auth would be to actually know what needs a prior auth, right? Do you actually know exactly every service that needs one by insurance provider? And do you have that documented? And it is a living, breathing document that kind of changes with the changes in, payer responsibilities and policies. When do you need to go down that prior auth path? What is the catalyst to begin that prior auth process? Second, identify those resources that do perform those prior auth tasks. Think back to those questions we had: the who, what, when, where, and why. Who is going to perform the prior auths? Who's going to back that person up when they go on vacation, or do your prior auths just not occur for a week? Again, thinking through that entire process before those prior auths are denied or just aren't getting done. It's a good idea again here to establish those specific policies around auth management and what those scenarios look like for those exceptions. If an auth is not obtained, what will you do? Is the service going to still occur? Are we going to delay it a week, a month, whatever? Have you worked that out, and has that been documented, formalized, and kind of distributed to the rest of your organization and hospital? Does everyone know what occurs when a prior auth doesn't occur? We're just going to run the test regardless. Again, thinking through those processes and having a written formal policy for those is good. So without going into the full detail for every other reminder here, again, your prior authorization plan needs to include a process for new clinical services, once the stay has begun, and to ensure that all that proper communication is occurring between all appropriate departments within your staff. I'd say holds or lapses in this prior auth area are somewhat common, but they also result in a lot of missing payments. So again, this is an area that we often see a lot of issues with, but to Kendall and Mahaska's credit, they had really done a fantastic job in tightening this up, having the pieces in place, and knowing the formal processes, and worked all out those contingencies, I'd say, to be in the right place for when these things do occur. And with that, we'll kind of move into, I'd say the last piece that I'll cover is that encounter documentation. This, I'd say, is probably the most important, I'd say, best practice we have here is to create a clinical document integrity team if you currently do not have one. I'd say a multidisciplinary team that is looking for accurate documentation, reviewing compliance, identifying any type of reimbursement changes, evaluating your charge master, and really setting up your entire revenue cycle for success. Best practices here would be, again, like Kendall mentioned, and to their credit, having that engaged leadership that is supporting your team and providing that strategic guidance on where you're going next. And once you have that established, team and you're supporting them, some of the items that your CDI team will monitor will include case mixes, your response rates, response times, and all those variables that may impact, I'd say, your quality and your potential of reimbursement changes. Again, what we're looking at through this, the CDI team is open communication, between your physician team and those folks that are impacted within revenue cycle. Coding, admission, registration, documentation discrepancies, all those things. I would say that the hospitals that we have worked with that we've seen some of the greatest improvements are those that didn't have anything along the lines of a CDI team or anything within clinical documentation, but have embraced that fully engaged collaborative idea and that approach, like Kendall had mentioned, that the leaders and the physician teams were all part of your revenue cycle. And I would say that would be one of the biggest takeaways is that, revenue cycle, people ought to think, oh, it's our billing team, it's our billing staff. But everyone that has any interaction with that patient, from pre-reg, scheduling, and your physicians, are a part of that revenue cycle process and do have an impact on whether or not you're going to get paid for those services.
I think it also ties, Ryan, that clinical document, the CDI team is a good way to get your clinicians involved to help them be your advocate and be your champion for things that need to take place. So, what are you doing? And if you want a way to try and get that engagement, find that friend of revenue cycle. There's at least one physician on staff, maybe not more than one, but, one physician on staff who understands that if you don't get the bill out the door, you don't get a good chance of getting paid. Find that person and see if they will join your team with you. And then through that, then some of the other initiatives that you take care of as part of this CDI team, then you can start focusing on other areas or vice versa, start them on those other projects and then bring them into a CDI team relationship.
Yeah, I mean, also that CDI team is really where you kind of start trying to all speak the same language. You take all the revenue cycle for them mumbo jumbo that's occurring, and you bring in the physician, and you bring in the coder, and you bring in the finance people, and you say, okay, what does all this mean that's occurring? What is happening from a physician perspective that is impacting you, and that translation and kind of that engaged leadership that all comes to an agreement that will happen within that CDI team and really does spur some true changes and kind of wins for your revenue cycle.
Well,
and with that, I will turn it over to Amy to cover the back end.
All right. So, we spent a lot of time listening to Kendall talk about the panel discussion. Kendall, thank you for that. And now we're going to start talking about Kendall talking about that. Then we had the front end activities. And now we're walking into this denial side. And so I know that you shared, a lot of you reported that denials are where your biggest challenges are and things like that. But when looking at this layout of the denial process, you can see that if it's broken upstream, you're going to catch it on the denial side. And really, if you can fix the ones that are happening upstream, then it gives you that opportunity to fight against the new things that the payers are bringing to the forefront, because ultimately we're fighting not only internal challenges that we're doing, but those payer challenges where they're using those AI tools. So with that, I am going to kick off our final poll. I believe this one, and then we'll have a closing survey. But go back. Did you just launch it, Hillary?
I launched it, Amy.
Alrighty. Okay. So thanks, Hillary, for launching that poll. I'm like, all of a sudden it showed that it was launched. Thank you.
And we're getting lots of answers coming in. Just give folks a few minutes.
Amy, as I'm looking at this poll, I wish there was a all of the above response, because I feel like it's probably one that you can probably answer all of these.
Yeah. It's almost like when you don't give them an all of the above, that you've got to choose the one that's
You've got to force
great.
the hand.
So we're sorry, but all right. Looks like we're about to the end of it. So we'll close it out in 5, 4, 3, 2, 1. It's the countdown. All right. Sharing the results with everybody on this one. How does your organization currently handle these denials? we address the denials reactively as they come in is the top. And then the next to that is we struggle to keep up with denials and appeals. Then we have a smaller percent, 19% are actively looking for new strategies to improve. And then finally, we have a dedicated team in place, a dedicated team and a clear processes in place. So those are the results. So what we're going to cover as part of this is just, first I want to talk about, oh, look, I forwarded the slide even if I was doing it myself. A claim rejection versus a claim denial, because there are two different things between a claim rejection and a claim denial. A claim rejection, if you think of it this way, is when it's not even accepted by the payer. It hits that closed door and it bounces back to you. It's rejected. Typically, this happens because you've got incorrect or missing data. The provider's clearinghouse or claim scrubber finds no insurance subscriber listed, or the number is invalid. Like when Ryan was talking about before, that if it's an alphanumeric characters and they're 9 digits and you send them 15 digits, it's not even going to make it in the door. And as part of this claim or rejection process, the timely filing window is still ticking. It's like for every day that you don't get that claim rejection resolved, you are hitting up against that timely filing window. Whereas a claim denial is when the insurance carrier has gotten it, and then they may, they've got it, they've put it into their system, but it's not paid. And so that's where, the claim's submitted timely, and now the appeal clock begins ticking because they've sent you back a denial. And sometimes it could be very similar to the claim rejection, like subscriber not found, that you could have had that 9-digit alphanumeric number, but it's not a valid 9-digit numeric alphanumeric number. And so they've sent it back to you as subscriber not found. So when thinking about this, there are claim rejections and claim denials. And we're talking today, really what we're focusing on are those denials. They've made it to the payer has sent it back. When looking at this, some
Now, Amy,
oh, go ahead,
I was,
Ryan.
and I'm sorry, I'm jumping in and
Go ahead.
interrupting you. I would say, we have seen a lot of EMR systems that don't follow this definition. Your denial list may say claim rejection list, but just to make that delineation between, hey, these are claims that made it to the payer, these are claims that never even made it to the payer. That's kind of the discrepancy. There are, kind of HFMA or kind of accepted terminologies, but we have seen many of the EMR systems that don't really follow that nomenclature and kind of do their own thing. So if your denial list says claim rejections, that's what we're still talking about.
And one of the challenges, and I will stand on it for just a second, is on this claim rejection side, that your clearinghouse may reject the claim and send it back, and you're having to work those as well. Still has not made it to the payer, and you're just trying to get it past their door to get to the payer. And we are talking about denials that are making it to the payer. So to realize that in this rejected, when thinking about those claims, it's like, payer hasn't received it yet, but you still have to manually touch it for some reason. So when looking at this, ways to monitor these claims and look at denials, it could be, let's work on payer payment dates where you're following up on the claims that are outside the typical payment date range. Like, for example, Medicare. If you know that a date of service was on February 1st and that it takes you 5 days to get the claim out the door, that's February 6th. Well, once you get the claim out the door, Medicare should pay you in 15 days, right? Medicare that's traditional Medicare. These Advantage plans, they're on their own. But traditional Medicare, they're going to pay you in 15 days. So you set up a report to really work claims that are greater than 15 days old, because you should have received a denial back, or you should have received a payment. Or if you got a denial, why did you get that denial? Another way to work the pay is working it based on payer payment dates is because of timely filing window. If you know that your payer requires you to get a clean claim in the door in 90 days, well, if subscriber is not found, that's still not a clean claim. While they've received it, it hasn't been applied to the patient yet, and it could still hit that timely filing limit. So if you know it's 90 days, then you need to be following up on the claim, say, at 45 days to give your team a chance to fight and get that claim in the door at the payer and processed at the payer. So, really looking at your denials or working at your claim status best practices based on payment dates. Go out, and another way to do it is to go out and look at your claim statuses based on trends by the payer. If you were to run an aging of your payer, and the aging has a balance of $12.22 for about 100 claims out there, that's a consistent outstanding balance. And you go back and look at it and say, why do I have this balance of $12.22? And it could be that's a lab test that's related to that vitamin D because you charged $12.22 for it, and it's not covered, and here's the outstanding balance. I mean, we see that over and over. And so when you go to that payer, you can say, oh, here's a challenge that we have and working on that. And then also looking at trends by payer for a specific provider. I know we talked about this with Kendall earlier, but when you've got a new provider for a facility, or all of a sudden you see that, this specific payer is not paying Dr. Amy's claims. Why are they not paying Dr. Amy's claims? And then you go back and you see Dr. Amy's got 300 claims out there over all of our AR. Why are they not going through? Then you can really work with the payers and understand what's happening and why they are not getting it. Another way to work your claims is focusing on appealed claims. Do you have a group of claims that need clinical support? You've got to engage a clinician in the discussion. That's, a great thing to have. We were talking to a client just yesterday, and they were talking about how they had received letters, communication back from the payer. And down at the very, very bottom of the communication that came through for them, they're thinking, oh, it's just a, notification letter from the payer. But down at the very bottom of that notification, it actually said, please submit medical records. And unfortunately for them, they shared with us that they didn't notice it in the first 10 claims that came through with this letter that they got back. They're thinking, oh, it's just a, hey, claims on file type of letter. But once they started digging in and looking at that specific payer, they realized that the communication said, hey, we need additional information for this payer. So when focusing on your claims and working them, looking at appealed claims, communications from the payer. Hey, do you have a bunch of them that they've received claim on file, but you still don't have a payment from them? Perhaps there's additional information in that communication. And then also go back and look at monitoring your claims by claims filing date. Do you have a day that there was a thunderstorm outside and your clearinghouse went down and the claims are stuck at the clearinghouse and never made it to the payer? If you go back and run your accounts receivable balances and you're looking at your claims by the claim filing date, it was everything that was submitted on February the 17th. That's why they never received it, Medicare. That's why those claims didn't get processed. So really, ways to look at it that you don't just have to go, look at what's on your work list, but maybe taking those work lists and filtering and looking at the information differently and changing that view. Then instead of seeing the same 5 patients that pop up every time, you look at it differently and it's like, oh, I never noticed that before. And so these are some best practices that you can use to look at that. The goal of denials management, though, is to really get to the root cause analysis, identifying those trends, because the more that you can work them in bulk, the quicker and that's like low hanging fruit. Well, sort of low hanging fruit. It maybe you're going to have several conversations with your payer relations and, have communications with them to share what's going on. But, it's by taking that first line of defense where you're protecting your AR. That's what you're doing in managing denial management and working your claims and looking for these root causes. Can you go back and say, oh, like Ryan gave the example of it's a 9-digit alphanumeric code. Do you need to set your system up so that you only accept a 9-digit alphanumeric code? And then that way it prevents any problems with the information going through. Now, in denials management, There's some key things that we see, and I'm gonna try and talk slowly in case JD, you're still listening in on the call. When thinking about common themes that we see, insurance ID, insurance denied, can ID patient. You really want to get to the root of that problem. Questions that you can start to ask. Ryan said, you want to start asking the who, what, when, where, why. Does your facility have eligibility software? Is insurance updated at every visit? If they can change Medicaid plans every 30 days, then you pretty much need to make sure that every 30 days it's matching. And then what documentation is used to ID the patient? The prevention service denied for frequency. Is there an ordering provider tracking the frequency? If you can only have so many um, uh, blood sugar level testings done in a month, does the provider know that? Do they know that you can only have this many procedures? We typically are familiar with those limits in revenue cycle, but have you shared it out with with the providers? And does the denial team inform them of that? Do you have that communication? And then there could be new ones that come about where it was like, wait a minute, last month they took this. Why are they not accepting it this month? And you go out and you research on the payer, and it's like the payer has changed their policy on the frequency and the number of tests that you can have. So really looking at this, getting to the root of the problem of, denied for frequency. We talked about a little bit ago about no prior auth being obtained. Are you getting that prior authorization ahead of time? Did you get it authorized before the service? Did you even know that you would require the prior authorization? Used to be that we had some real repeat offenders on some of our payers out there who like to use that. I've seen that it's back down a little bit, not as much as we would like it to be, but what is your process for that? And then medical necessity. You know, does your team, are understand the payer policies, and are they housed somewhere for viewing? If somebody new, if a new payer comes in, do you know what they're going to require for medical necessity? Do you inform the ordering and servicing departments? It could be in radiology, or it could be a referring physician. Do you have those communications with them to share that we've got to have a medical necessity required to it? And then do you have that proper coding? And are you reviewing the information that's out there? That when you have that medical necessity denial, I'll tell you right now, a lot of those AI tools that Ryan was talking about before, one of them is just saying that if it is an unspecified diagnosis, that they are rejecting that claim because they're saying it's not medically necessary because it's unspecified. Because in the payer's mind, they're saying you should be able to get to the highest level specificity, so therefore it's not medically required. When looking at trends and anomalies, when looking at this data, you want to make sure that you're asking why 3 times, because you know what? The first answer isn't always the right answer. You got to dig deeper and get into it. And then also, the first answer isn't the only answer. There are multiple factors that impact these things, and it's like we're working on denials. And if you think of it as this big pot, well, in that big pot of soup, you've got your potatoes and you got your meat, and there are all denials out there. And sometimes you just got to go through and find all the carrots first. It's like to say, what are all of those things that are making up this denial issue? And can you get to the root cause? But then to realize that there may be another denial coming through. And so you really want to start spot some trends and anomalies for your payers and the information that's out there. You want to look at it, the denials and rejections in different ways. We talk about, are you looking at it by payer? Typically we just look at it as they're coming through. Here we got a new denial today. But maybe we need to step back and look at it by payer. That we think we've signed this great contract, but they deny 90% of the claims. Okay, that's a problem out there. Looking at it by service line. Is this everything that's happening in the wound care department or in radiology? Go through and look at it by CPT code, looking at your rejections and your denials, the aging bucket, maybe dollar value. Do you have pockets of opportunity in there? Then instead of just getting them as they come in, you step back and go, wait a minute, we have a problem in everything that's in this 61 to 90 day bucket, that we've got this common, with this payer. Why is this happening? What happened 60 to 90 days ago? And what can we do to get these claims fixed? Did you have someone new that was hired? Did you have someone that used to do the job that's no longer there? There could, you can identify those root causes and go through. And then finally, just looking at, does it pass the smell test? It's like, we all look at some things and go, this doesn't feel right. You know what? Sometimes you can phone a friend and just go, are you having this problem? Because this doesn't feel right to me. And, Ryan and I have had a lot of those conversations with people who are just like, I need to run this by you. Does this smell, does it pass your smell test? When looking at denials and working through it, you really want to develop a multidisciplinary approach. You know, do you have clinical involved? Are you involving patient access? Do you talk to finance? Do you have IT? Can you fix system changes? I think that maybe a common theme that you're hearing throughout these presentations is that revenue cycle, we've got to involve everyone in the process, because while we see it at the end of the day, sometimes we've got to go back and talk to them and share it with them. And in working these denials and creating this multidisciplinary approach, we got to realize that we may have to talk their language. Like when I talk to JD, I might have to slow down my conversation just a tad so that he's understanding it, and then ask him, what did you hear that I said? But really working within your organization to foster an environment of continuous improvements, where you set short-term goals for correcting major issues. You celebrate, take a moment and celebrate that you solved it, and that yes, we've got more that are coming down the pipe, but we solved this one today. And really continuously training and educating your staff on payer changes, policy changes, behaviors that they're doing, to really look at that, to then go back and look at the data and analyze it again. And then on this next slide, what we share with you are just some things to look at when working with these. And I won't go through all of these, but we've given you some ideas that we're going to share as part of the deck, that when you're looking for like insurance denied, can ID the patient? Here are some questions that you can ask related to them. Medical necessity denial, putting that information out there, asking these questions, and then working within that process within your organization to answer them, putting together that team to do it. But then also using this information to build a relationship with your payer, to go back to the payer and go, hey, here's what we are seeing in the data that you have that the claims that we have. You know, do you have do you know what the payers cause the most headache and have the greatest ROI? In which contracts, maybe not so much. We're just going to let that one go. What does that need to look like? But you really want to have that relationship. And you may just start with one. You don't have to have relationships with all of them, but really clarify what the contract says and how you're going to be paid. Because especially in a critical access hospital with your advantage plans, they are supposed to pay you your rate unless it's otherwise designated out in your contract, specified in your contract. So really having those communication, accepting, understanding how they want to receive that rate letter. And then also looking at the value of the analytics within your revenue cycle process, really capturing the information where you can identify, have you caught everything? And what this does is, by having analytics, being able to look at the data and digging into it, providing that clarity and bringing the teams together on common goals, that's how you help get these other areas engaged in your process. And by having that data, You will assist in messaging to teams and leadership. Sometimes we've got to step out of being down in the details and, well, this is what this payer is doing and this is what they've done today and all of that nitty gritty, to really step it up and go, what are those top 3 things that I can tell you I need assistance with? And messaging that and giving them the data to support it and working through that piece. So with that, we do give you on the next few slides some key indicators that you can track. However, because we are like right up on time, I did want to just be respectful of the time that you have given to us today. We do appreciate it. Going back to those key indicators, if you have any questions about anything that's been shared, please feel free to reach out to myself or to Ryan. Know that Stroudwater is here. As I said, we live in rural healthcare a day in and day out. We see your challenges, and we know that, you too can have a great organization, and we're here to help you keep that healthcare local. And we do have a poll at the end of this. So just to help us to understand what your top priority is after this webinar, areas that you're going to focus on, if you could go ahead and complete that for us. And then as you leave the survey, we want to know, was this beneficial to you? We've had a lot of discussions and shared a lot of information with you today. And again, I do value your time. I know that you have small staffs and you wear a lot of hats, and just happy to connect with you at any time on any questions that you may have, and just say thank you for joining us today. And with that, then, Hillary, I am going to hand it back over to you and you can close this out.
Yes, thanks so much, Amy and Ryan and Kendall and JD and everyone that joined us today. This is great. It's great to see so much engagement, learn so much about revenue cycle management. Thanks for participating in the poll. And everyone will receive a copy of the slides and a link to the recording if you had to miss any of it. And hope to see you again another time.
Thank you, everyone,
Thank
and
you.
have a great day.